as it is. So I think you kind of the diet fast toast. You could, so with the AIM trial, you could try and treat this more operatively with a close contact cast. But if you do that, you've got to watch it like a hawk, because this is going to try as hard as it can to fail.
Taylor's is taking freedom to get on again.
We talked about the vertical shear fracture setting the impaction on that side. This one will almost certainly have toasted that lateral platform as well. So it's everything possible that toast is going to try and go out. So I think you're going to struggle to control that with a close contact cast, but you could definitely try. But if you try, you're definitely x-raying it weekly for 3 or 4 weeks. 2 weeks isn't enough because it'll go late. And if you're immobilising diabetic, it only takes twice as long. So let's see what else.
So with diabetics, it's basically the adage is twice as strong for twice as long.
Do you routinely fix these with the Protodino? Do you routinely fit the Protodino screws in these?
I think it's good. I would be good if I would. Yeah. Not everyone, but I would. I can't see why not.
So if this guy was much older, say 10, 15 years older, you might well stick on for now. It was certainly going to put 3 or 4 Pro screws in to that and fix it as strong as you can. And despite that, you're also getting immobilising.
Yeah. To a certain extent, that question versus the tubular plate. So if you actually use multiple screws through into the tibia, effectively you're using the tibia as a second plate to the fibula. And the downside of having to use stronger plates is you're more likely to get into wound problems. So it's about having a really robust reconstruction, and if that means putting multiple screws through into the tibia, then that's a good thing to do. And it means that essentially you can keep your plate laterally more on profile, so you're less present.
There's a fair bit of the locking plates laterally as a high up and start to break down.
So these guys aren't typical 48-year-olds. So his 5-year mortality is probably 50%. If he's got peripheral neuropathy, I don't know if he has that.
Yeah, so that's another quick aside. So you get a patient who said, "Well, I think my sensation is normal," and whatever. Do you know any quick test that allows you to establish whether they've got neuropathy? Because you can never find them on a film. They're locked in a box in a safe in an office 10 miles away.
Yes.
So what do you mean by that?
So you're touching 6 toes, the great, the middle, and the little, and if they miss 2 of them, identifying which one it is.
Yeah,
probably.
okay, so it's a touch test. So basic tips of 3 toes, and of course you could say with that displacement, but if the other foot is 3-toe positive, then you're pretty guaranteed they've got neuropathy. So you can't 100% depend on the big displacement side, because it may be a secondary effect of displacement. But yeah, so touch test is very practical, very useful. Anything else that you know of? So because you got it right, I've got to test it even further now. There is another trick that's very contemporary. It's for old people like me. I'm going, what? Now you can load up an app on your mobile phone that is a vibration test, and it will tell you whether they've got sensory deficit to vibration.
He wants to stick with that personal. Load up your losses.
But the touch test is
Good. Okay. Right,
it's
next.
so simple, so practical.
Next question. Okay, I'm going to show you the X-rays. Okay.
Show the X-rays got it.
would you definitely think prior to that?
CT scan.
Yeah, you need to really understand that injury, because it's not right and it's falling apart.
So what's wrong with that fixation?
Reduce the talus under the tibia. Haven't reduced the talus under the tibia. That's
So it's
probably
just the fracture reduced.
most probably either the wrong length or it's malrotated.
No, it's all right. So
The fibula's okay. What's the problem?
Posterior mal.
That's the tip of the fibula up there, isn't it? And so it's probably linked.
I don't think it's
awful.
So it's never reduced the symptomasis.
Yeah.
Yeah.
Syndesmosis, that's the whole point with all of this, and this is, you hear people talking about the syndesmosis and fixation, or whether you should or shouldn't fix them. Well, if you're going to fix them, make sure the damn thing's reduced. If you fix it in the wrong place, you're not going to get a good result. Hence, you're better off leaving it alone, as some people would say. So the problem with that is he's got a big chunk off the back, and that talus is subluxing out posterolaterally, and it's going to stay there unless you do something about it. And fixing the fibula, whether you get the rotational length or anything right, if you don't get the syndesmosis right, and that bit of bone back in place, the talus isn't underneath it where it should be. So it's the bit of the back that needs sorting out there, and that's not easy at 3 weeks.
So you've done this as a registrar, you're looking at it, and you're thinking,
You're taking a roasting by that stage.
so you're talking about fibular length and rotation. What other thoughts do you have as to why this might have happened?
Syndesmosis be malreduced.
So, okay, so that's another reason why you need a CT, is that because you may have fragments of bone that are just blocking things that you haven't appreciated at the time, and that can immediately or laterally. Anything else? It's rarely ever the deltoid. The deltoid's squidgy and it will probably get out of the way. But you can occasionally see tib posts happen in the middle of that. If it's been displaced enough, it's like that that picture we saw before with that massive displacement. Well, just about anything immediately could have got into that joint legally. So that's another possibility as well. So soft tissue blocking as well as bone blocking.
What percentage of these posterior fractures have got die-punch fragments of bone in them?
Most is a high percent.
Yeah, it's like, well, I think it's over 80%.
You've looked at this.
No, whilst you were doing the studies.
But if you see, it's one of the big arguments, as Ian says, for doing CTs, because you can't see them on these plain films.
So there's almost always a blocking fragment. So if you think of any posterior mal fragments that peel on the bone, essentially. And if it's a small shell and you're only reattaching it to reattach the posterior inferior tib fibula ligament, and that's possibly not a big problem. If there's a big chunk, you definitely want that blocking fragment out. You don't know that's there. And you've got no idea what orientation, shape, or size that is until you see it.
The one we did yesterday, Peter, the fragment was actually in the diastasis, and you couldn't see it on the plain film.
So there are, if you start to research syndesmosis injuries on PubMed, there are thousands and thousands of papers, and various papers looking at what you need to section to actually get a diastasis, and you actually have to disrupt quite a lot. So and the interosseous membrane even up here is giving you some stability. So when you don't always assume that you do need to even have any fixation across it. Sometimes just fixing the fibula anatomically itself will be enough. Sometimes fixing that and the posterior mal, often that is enough. And then if you're then reducing it, there's all sorts of studies looking at malreduction, and if you look at just plain films of intraoperative II reduction to reduce syndesmosis, about 50% of them will be malreduced. And then there's a nice paper that looked at doing an open reduction, so a small anterior incision, and you look for that Mercedes Benz sign. And even if you do that and do a post-op CT, 15% of those are malreduced. So you're stuck between a rock and a hard place. They're very, very difficult to reduce. And so we would advocate either opening them up or sticking a scope in to have a look.
That was my mischievous question. What would top flight units do? And of course, they'd scope it at the same time as fixing it.
And have a very, very low threshold for CT and post-operatively and looking at both of them.
Of 50% of them are reduced, how many have long-term problems?
Well, that is, so those papers haven't necessarily correlated that, but there are other studies that show that if you have any slight displacement of the talus, so if you get a 1 millimetre displacement of the talus, you'll have a 40% increase in contact pressures, and then the increase in contract pressures is associated with increased risk of.
But where your question is absolutely right, is just because you've got a degree of malreduction in syndosmosis doesn't necessarily mean that the talus is malreduced. So that when you're looking at a CT, what you're critically looking at is the reduction of the talus under the tibia, and that's the thing that's going to determine the prognosis. Obviously, that is associated with the degree of displacement of the syndosmosis, but that's why you can have little degrees of syndosmotic malunion and it not really affecting the patient.
Yeah.
But it's all about when the talus is.
There's a general rule with this, but rule of thumb, trauma meetings in the morning. If you've done one of these, or if you're in theatre and doing one of these, and it doesn't look quite right, it probably isn't right. And those are the ones, worth you getting the CTs on if you're in any doubt. Because if you don't think it looks quite right, chances are you're right. There's something wrong. You've got to find out what it is.
Right, next. Change the question again. So it's really short, isn't it? So we're right, see you later.
What's the evidence for fibular length though? I was speaking to a consultant this week about it, and he suggested as long as the medial column is stable, fibular length doesn't matter.
To a certain extent, it's the same principle. So it's all about the reduction of the talus under the tibia. And as long as the talus is reduced under the tibia, then actually everything else is up for grabs. And it's probably true that that's a component of the end of the trial. That we assume all the time open reduction, internal fixation. Everybody needs that, don't they? But actually, it's all about containment and placement of the talus and the tibia.
So you're right in a way that actually the talus should be completely controlled because the deltoid should be intact.
Yeah.
Because there's a fact this looks well reduced. So in theory, that should have done right, but as he's got ongoing pain, it probably is because of that.
Yeah.
But I would argue that fibular rotation isn't right as well.
Yeah.
It doesn't look quite right.
So the answer to your question is, okay, fine. If you've not got a problem and you've got a short fibula, why would you worry? But if you've got a problem and you've got a short fibula, then it's probably relevant and it's probably linked to rotation. So it's not absolute. Any of these things are not absolute. It's all matters of degree, and the key to it, talus and the tibia.
Okay, that's all. What's the worry with this injury?
Avascular process.
What's the sign called? That's good.
Hawkins sign.
So what's the answer? Yeah.
What type of fracture?
So yeah, so what type what's the Hawkins classification of this?
Need a CT scan.
No.
Did Hawkins
Minimum
have a
review.
CT?
Yeah. Hawkins was pre-CT, so you can't go with that.
It might be fair enough to show you an MP, but I haven't got that.
At least the two.
So is it says at least a 2, but is it a 3?
You've got complete fracture, complete displacement, but you haven't got dislocation of the tail.
So your subtalar joint's dislocated.
Yeah.
So one is pretty much undisplaced, two is subtalar. Talar navicular is in joint, isn't it? So that's three, so it's a two. And if it's a four, it's the ankles.
So what's
So
the,
despite that looking like a quite dramatic displacement, theoretically that's a two.
Yeah.
so what's the instance of AVN with that injury? Gordon Hawkins.
But again, this is one of those sort of historically quoted papers that was based on.
How many patients? It's about 12, isn't it?
Yeah, so one, the patient group was very small. Two, of course, it was only ever done on plain X-rays, and the delayed treatment was considerable in many of the cases. So you're talking about not what we tend to do now, which is get them primarily reduced and then definitively fix them over a few days. You're talking about some of the cases actually hadn't had definitive treatment for a month or something like that.
So we've looked at quite a big series from here, and I can't remember the rate, the ABM rates are very low.
And that included
So the-
type 4.
Yeah, so type 3s and 4s, if you look at contemporary literature, it's a little bit in my talk, but it comes out as about 20% have proven AVN, and that's complete. You get patchy partial AVN, which may be irrelevant in this one. So it's not as common as it's thought.
Okay, next one.
But again, exam-wise, you should be able to quote that as the original and then critique it and say, actually things moved on and it had flaws as a paper and so on.
We've got the next one. So what Hawkins classification is this one?
Yeah, four.
So that's the X-ray. So definitive management.
Yeah.
Yeah. So what's going to be your initial management of that? So they're coming to A&E at 7 p.m. on Friday. There's a shoulder surgeon on call for the weekend. John?
So you'd assess to see if it's an isolated injury, manage it as per ATLS because it's a high energy. See if it's neurovascularly intact. You want to try and maintain the talar fracture fragments. Ideally, if you can reduce it in A&E, that would be great. Wash it with some saline, take a photo, manage it as per both guidelines for open fracture. And you want to get that reduced as soon as you can, safely in theatre.
You can do that on Friday evening or Saturday morning?
Depends if there's an available foot and ankle surgeon who might be available on Saturday morning. If there isn't, then and it's within reasonable hours, and or if there's any neurovascular compromise, I'd do it on Friday evening. Otherwise, I'd wait until Saturday morning.
I think I would argue that that's an emergency, and that is probably one you wouldn't leave till the morning, and it doesn't get a foot and ankle surgeon.
I mean, you could argue, playing devil's advocate, that it's open, if that's stuck out, that the skin's not compromised. But as a general rule, these are closed and you get that sort of opinion and the skin's under pressure. If you leave that to the next morning, you can have a white bit of skin over it, which will then go black.
So this was said to be an open injury, wasn't it?
Yeah.
Yeah. So what's the commonest problem that you see?
Acute.
The commonest problem is it's grossly contaminated. And we've had people sent in with well-reduced talar fractures open, who you actually re-explore them and find straw and poo in the wound.
So the primary management of this is the management of the soft tissue problem. And in order to do that, you have to reduce the fracture, but you must debride it and wash it out thoroughly and get all the stuff out, because at this point in time, potentially you've got the largest sequestrum in the world sitting in there. So the primary treatment is to make sure that you've done all the normal soft tissue stuff about managing that, making sure that the wound's decontaminated thoroughly and completely. And as part of that, you've got to get that body back in the right place.
So what are you going to take?
And then it's open for grabs whether you actually need to fix it or not. And you can, at that point, say, well, okay, fine, I've got it reasonably reduced, and I'm going to wait until my foot and ankle collar is there, because it's going to make sod all difference whether you, if you've managed to reduce it, definitive fixation at an early stage. But if you can't reduce it and you have to fix it to reduce it, then that's a different ballgame.
What are you going to take to theatre with you?
Plastic surgeon.
You want to keep them out of the game. Pain in the arse.
They were cheap a bit.
Yeah, oh, a bit of equipment.
Distracting.
Make sure you've got a distractor at hand, because a high percentage of these won't go back. You have to stretch them to get it back in.
So the old femoral distractor works.
We've only got one.
Yeah, there's the
Hoffman.
big AO bobbly wire distractor, that works.
Yeah.
Just a Hoffman
Or a
fixator
Hoffman.
with somebody all in on it. works.
Hoffman, but you can, if the trouble with Hoffman is difficult to distract, so if you're going to have that, put your blocks on and you get your lamina spread from the spinal set, which is about that long, and put them between two blocks. But you need quite a lot of power on these, often to get it open enough to get them in. And if they've got, so if they come elsewhere with the distractor on, and the thing's still dislocated, don't take the bloody thing off till you've got it reduced.
Okay. Right, 8.
Hey,
Any other takers? There are annoyingly a load of questions like this in the exam.
Go, what's your show handle?
Yeah. Okay, so A, hands up. B, C, D,
So
E.
what's this one aimed at?
I'm not sure what the answer is.
that's
I'll shut up.
American.
Let's have a look. E. The workers' comp patients have a worse outcome, but I think.
So that means the sedentary jobs, they're all right. It's the physical jobs that are the problem. Yeah? So you go back, read that, and then go back to the list. So Sanders 2B, which study actually looked at that? That's actually the basis of the HEAL trial more than anything. Though there were so many exclusions from it that some types of 2B weren't included as well. But 2B, what's a 2B fracture? What's the 2 count as?
Two fractions on there.
So yeah, it's two fragments across the posterior facet, really. And what's the B?
Just one middle of that.
Yeah, so it's central, base central. So that's 2B, simple as that. So it's actually a relatively benign injury in truth, because if it's central, it's less likely to have a big lateral wall fragment. If it's medial, it often is unstable medially. So that's a very benign injury to be in theory.
You win.
I don't know.
Okay, next one, let's see. Okay, so that's a stress radiograph.
So it's boundless questions you can play. So should we see the answers? Okay, so- Got a little title for it. Okay. You'll email this round afterwards.
It'll be on the website.
Okay. Oh, sorry. Right, last one. Are there any other extras? So you have more imaging, wouldn't you? What do you think? That's a slightly unfair question, isn't it? You don't really know what the injury is.
Yeah.
But when you see this plantar bruising, very, very suspicious of a mid-strike. So you need 3 views, so you definitely need a lateral. You can often get AP in people that look relatively normal, but you miss the popped up second metatarsal, but you want a CT scan.
What's the biggest problem with these? General question.
What you missed?
Yeah, what percentage you missed? It's about 30, isn't it? It's about 30% are missed. And of the ones we know of, the X-rays that underestimate the severity of them, about 60%. So if you don't think about it, you'll miss something.
And certainly that needs, you can't make a decision on the basis of that sole X-ray. It's inappropriate and want to even ask that question. Anybody who has that appearance needs a CT scan to fully understand the lesion. The reality is the prognosis of ligamentous injuries that are truly unstable is actually relatively poor. And the problem why they get missed is that they're often trivial mechanisms or sports related, and all sorts of people get involved in their management instead of them going down a conventional trauma pathway, if you want.
I think what you'll be frustrated about the MCQs is that you'll do the exam and you'll come out of it thinking, I have no idea about a load of those questions. And you'll do all the revision and there'll be really random questions that will really annoy you because you won't have all the answers and you just have to sleep off and go through your guts. But that's a very common thing, so just be expected on that. So we've got a load of cases, X-rays that we can go through, which I think is probably the most useful thing, but we've also got a few talks. So we can sort of, if I start off with you, try and give you some 5 minutes of my thoughts on ankle fractures, and then we've got a little bit on Kevin Taylor's.
Something wrong with projecting what's doing. It may be, if you go to settings and go to your screen resolution,
It's down max.
if you go to settings.
Anyone know how to sort this out? We can do it like this, I think.
How many, what, an here 32?
So, we'll see if this works. This is just my thoughts on microfractures. You all know how to treat microfractures, so I'm not going to talk about that. So,
Yeah, not when you open.
You had the AIM trial to read. One of the examples wants to give a brief 2-minute resume of the AIM trial.
So it's a trial, I think 600 to 700 participants. They were, the inclusion criteria had to be 16 or over, and fracture that was unnatural. It was, had to be reducible in theatre, and for the possibility of going to the pastor. So basically the trial was split into two. It was either surgical management as per the normal surgical protocol within that unit, or you went into close contact casting. The close contact casting group was fixed theatre for either spine or general anaesthetic, and then they had a specific protocol for their close contact casting which was put into place. Subsequent loss of reduction could either lead to them coming out of that part of the trial and going into surgery, or they could go back to theatre or in the outpatient department and with further close contact casting if they lost their reduction. On the surgical arm, I don't think there's much more else to say. Effectively, the results ended up with the outcomes being the same at, I think it was 1 year, and then they're very comparable. There's not an awful lot of difference between the two groups.
So you're right, it's banded around that maybe we don't need to fix ankle fractures anymore. And so I know that Mr. Winston's got his views on pragmatic randomized controlled trials. So does this just take us towards mediocrity? So does this show us how bad we are at fixing fractures? Or does it show us that actually non-operative is fine? And sometimes these trials aren't that useful in day-to-day practice. But so our experience in Southmead is that we've treated quite a few of them like this, but you've got to watch them very carefully. So the important thing is the protocol was under general anaesthetic, 4 weeks of normal touch weight bearing. And more often than not, the way we do it now is it's put on in the plaster room and they're weight bearing immediately. So that immediately is a group that's not comparable. The analysis was, they were meant to do it per protocol, but they also went back and looked at intention to treat and also post hoc analysis as to actually what treatment they received, and they still found no difference. Important thing to say that within their protocol, you were allowed to convert to ORIF if you lost position. So even those that got converted to ORIF still got analysed under the close contact cast, and there was a 20% conversion to ORIF in the close contact cast group, and 4% of close contact cast got remanipulated under GA, and another load of them got done in the plaster room. Higher percentage of infection in the operative group, as you would expect. I suspect this 1% is because the non-operative group, 20% of them got an operation. Malunion was much higher in the close contact cast groups of 15% versus 3%, and medial malleolar non-union was much higher. They've just published the 3-year results, which still showed no difference. However, that on more subgroup analysis, if you had a medial malleolar non-union or malreduction, you had much worse functional outcomes, or significantly worse functional outcome scores than if you didn't. So my take-home message, I would say, the exclusion criteria as you went into, these are all the reasons why we choose to use close contact casting patients, yet these were the patients who were excluded from the trial. So that's worth remembering as well. So I think my take-home message from it is, it doesn't matter whether you fix them or don't fix them, but what you're aiming to achieve is mortis congruity. If you can keep the talus under the tibia, that's probably reasonable. And I think where we fall down with close contact casting is that we get a bit complacent with it. 2 weeks is fine, and they just get seen by someone else in the clinic, and so then seen at 6 weeks, in which case it's gone and it's too late. So if you want to close contact cast them, you should definitely see them weekly for 3 weeks, and be very critical that you're keeping the talus where you need to. And the group of patients is very useful for are those patients, but you've got to weight bear them. You can't not weight bear an elderly frail person. So if you are going to do it, that's fine, weight bear them, but follow them up very rigidly, and make sure you don't let them make displace, because then you run into trouble. So there are a few things that I think we can discuss. So you'll still come up against people with an exam on national who'll say, I was sent around as a junior registrar and saw an ankle fracture clinic and you kept your weight off it for 6 weeks. And I think that in this region is not happening very much now. Most people are quite aggressive at weight bearing patients. There's a trial going on at the moment nationally, but we're part of, but we're not sort of managing to recruit terribly well because we keep forgetting about it. So this is comparing any ankle fracture, whether it's fixed or operated on, for immobilisation in cast or into or functional rehab in a boot, and that would be walking. And what it doesn't say in the protocol is what you're doing with the cast in terms of walking with it. So this will maybe give some more answers, although I suspect what it'll come out as being will be equivalent like all of the other trials. But at least it'll give sort of some evidence that you can use a boot for them. So keep a lookout for this, which will probably take a couple of years to come out. But I think the key to deciding what you're going to do with your weight bearing is assessing stability. So you're all happy that you see this vertebrae fracture in the fracture clinic. You're all going to stick that in a boot, weight bearers, and not worry too much about it. And likewise, you see this on call, and you're all going to be pretty happy. You're going to reduce that, and you're going to fix it, or you're going to close contact cast it if you want to do that. But you're going to be worried about that one. But then, what are you going to do with this one? So you've got a Weber B fracture, and it looks pretty reasonable. So are you going to weight bear that one?
Yep.
So you're going to need to prove that it's stable. So this is all about the dreaded Lau-Hansen classification as well. So it's about distinguishing between a supination external rotation type 2 and 4. So if the medial side is intact, then it's safe, it's stable, the talus is going to be contained, it's not going to be moved. It's not going to move. But if the medial side isn't intact, you're going to worry about it. So you're either going to keep a closer eye on it, or you're going to fix it. And it's very hard to know whether there is a medial involvement. So lots of papers have looked at clinical signs, so bruising, tenderness, and swelling, even between SCR type 2s with no medial injury, and bimalleolar fractures where there's definitely an injury because of the fracture, or deltoid injuries. And there's no correlation between bruising, tenderness, and swelling. So clinical examination is useless, even if there are no signs, even if there are signs. So studies have looked at MRI scans, stress radiographs, which are difficult to reproduce and quite intensive. You've actually got to go and stress it yourself in the X-ray department. Gravity stress radiographs were used here for a while, certainly at the BRI they were quite into them. And now we've moved on to weight-bearing mortise views. There's a nice paper that shows that if you've got a positive out of 9, or so something like 10 positive gravity stress X-rays, and if you compare them to weight bearing, you only need to operate on one of them. And that all comes down to actually what's stabilizing the deltoid. And it's the posterior aspects of the deep deltoid that is most taut when you're weight bearing. So that's why gravity stress, when the foot's in equinus and flopping down, the talus can rotate and look like it's coming up. But if you stand them up, when the posterior tibiotalar ligament is at its biggest, at its sort of tightest, that's what controls the talus under. So I think I would advocate weight bearing mortise view for all of these, and if it's stable, then put them in a boot and weight bear them. So my algorithm for these then is if it's an unstable fracture, because you know it's unstable, there's been talar displacement, you're either going to fix it or close contact cast and take a very careful look on it. If there's no talar shift, you've got to prove it's stable, so weight bearing mortise. If you've proved it's stable, full weight bear, and then get them out of the boot regularly for range of motion activities. And if it's not stable, then fix it or close contact cast. Any questions about that? There's a really nice editorial about that from the BJJ that I can forward if anyone's interested. So this is another thing that you will get this banded around everywhere you go. And I think we talk about it less and less here, or we only talk about it when it annoys us, but nationally people still talking about it. This is based on a paper in 1940 with 8 patients, and someone thought, oh, it looks like a good idea if it's that big to fix it. It's all based on, well, and then people have subsequently looked at it and thought, well, it's trying to work out what percentage you've got depends on the contact pressures, and we know that increased contact pressure is associated with arthritis, but that's still not totally helpful. So this is, Haraguchi was probably one of the first guys that started saying you need to CT these, and he had a paper in 2006 and classified it into 3 groups, type 1, type 2, that goes across to the medial side, and type 3. And subsequently people have looked at this and there have been slight variations of it. It might alter how you fix things, but certainly having a CT scan really helps you decide how you're going to fix it, what your approach is going to be, what your patient positioning is going to be, and what your blocking fragments that we looked at are going to be. So why do you fix it? You fix it for, I think, one, mortise congruity. So Mike Kelly always does a nice talk where he shows what looks like this fracture and the carpus is dislocated forwards. A volar Barton's fracture, and everyone says, well, I'll fix that. And then he flips it out and it's an ankle fracture. So if the talus has gone out of the posterior bit, then that's very obviously that needs to be buttressed back in to contain it. So that's obvious. But I think the sort of less obvious is the syndesmosis stabilization. So that posterior lateral aspect has got the strongest ligament attached to it that stabilizes the syndesmosis. So even if it's a really small bit, fixing that back in is really useful for restoring the fibular length and the position of the syndesmosis, and often means you then don't need a syndesmosis screw. And as we were saying earlier, syndesmosis reduction is probably one of the things we do the worst at, and so if you can use anything you can to help you, then that sort of tries to help minimize those complications. And then if you fixed it rigidly, you can also mobilize the node. So you can weight bear them, and you can also get their ankle moving up and down. And that's all I've got to say on ankle fractures. Has anyone got any questions about it? If not, we'll probably pick them up on the cases.
When you fix syndesmosis, what's your weight bearing plan? Because everyone seems to argue about this.
I will weight bear them. I wait till the winter heal, so I normally do 2 weeks in a cast and then I'll weight bear them in a bit.
Screws left in or take that?
Leave them in. So there's it's not a trial, but there's a review, as a sort of a meta-analysis that has shown that there's no difference taking them out or leaving them in, unless, so if you see them in a year and they're stiff or they're painful, then you can take them out, but otherwise economically it doesn't make sense to take them out. So there's no difference between 3.5, 4.5, 2 screws, 1 screw, tight rope. Well, there's slight emotion with the tight rope might be better in some cases, but you've got to be quite
So there's quite a bit of literature that suggests that tight ropes are better, but it's all written by people who mysteriously are sponsored by Arthrex. And some of it's really good science, and you shouldn't decry it, but there is an intrinsic bias in it. So I'm trying to be unbiased in my behaviour, and now we're compromised because Arthrex sponsor the advanced foot and ankle arthroscopy course, so weird stuff.
So I looked at this for a talk I gave on fellowship in Sydney, and there's only actually one, biomechanically, lots of studies that would suggest a tight rope is slightly better. So screws definitely make the syndesmosis stiffer than your natural sort of syndesmotic movement. Tight ropes are slightly looser. So it depends on which side you want to go. The problem with tight ropes in all the trials have been irritation from the knots laterally and medial irritation, and sort of problems with that. But now there's been a randomized controlled trial looking at knotless tight ropes versus screws, and that came out as a very slightly significantly better outcome in the knotless tight rope. But they're all small trials. They're maximum about 50 patients per group, and it's quite a heterogeneous group of fractures. So it's unclear whether they've included major nerves or fractures. So it's very, very difficult to be.
And there are some basic science stuff with tight ropes suggesting that the syndesmosis will reduce more accurately, because you're not determining exactly how it does it. You just put the thing in the right place and tighten it up, and it will then snug down, is the idea. But again, there is a bit of bias about it, because all the names associated with those studies are people who, if you see them at a meeting, they'll put I consult for Arthrex and stuff.
I think they are it's slightly more forgiving than tightrope probably, so you probably get away with having your diastasis not quite reduced, and that's my worry about
Yeah,
it, that it's
Because
being
it's,
used because
it's
it's
a
easy.
little more flexible.
So probably that was the most impressive paper I found, is that they did a study where they simulated malreduction. So they used the clamp to purposely malreduce the fibula. They did anterior off-axis clamping and posterior off-axis clamping. Then either put a screw or a tightrope in. If you put a screw in, it fixes it exactly where you've malreduced it. If you put a tightrope in, because it's slightly looser, it has the opportunity to sit back where it wants to. And then when they scanned them afterwards, they found that the tightrope were better reduced. So it possibly slightly mitigates against poor surgical technique.
So when was the first randomized controlled trial that showed the results of the AIMS trial, or the equivalent of the AIMS trial?
There was a pilot study in 2004, wasn't it?
So 1984, there's David Rowley's PhD thesis was a randomized controlled trial that was basically identical to the AIMS trial and came out with more or less identical results. I mention that because sadly he died this week. But 1984, and that's a future challenge, because in essence we haven't really moved on since 1984. We're proving the same things again and again, and it's about accuracy of reduction. And if we really want to move forward with ankle fractures, that's why I get at the pragmatic studies. It's an audit done as an RCT, and we need to move forward and try and make care better, not what we were doing in 1984. Minor challenge for all of you throughout your careers.
Okay, so the MCQs took longer than I thought they might do. You can have a talk briefly, hopefully, on calcs and or Taylor's fractures, or we've got loads of cases that we can go through. And we can either start doing some of that now, or we can have a quick 10-minute tea break. So we can do whatever you guys would prefer.
Just a talk.
Yeah. And then we'll do some. We'll have a one talk now, and then quick tea, and then we'll see how you feel.
Yeah, sounds good.
Okay.
Pete, the only thing to say is the coffee shop's only open till 3:30.
Okay.
Why don't you get coffee now?
Yeah.
Get a drink and bring it back in here.
Yeah.
I know you're not meant to.
All right, stand like this. You're on YouTube.
Yeah. Right. So how does that show people log into it? They're on board.
There you go. Yeah, thanks, what were you doing? In the snack. Yeah, so you just go all the way on the other side.
Well, yeah, I mean, I can talk for half an hour. The classification side, so you guys can look up. So I'll buzz through.
Basic principles.
Go through just some basic principles of surgery, and then we'll talk about the heel trial for a couple of minutes. Because once we let Winnie up there,
He will go for it.
What do you mean?
I'm all right.
So essentially, this was my life for interest.
Was this in the Arctic too?
Very peaceful, apart from the mental health crisis that one of the girls had on day one. So that
Which girl, like contestant,
contestant, yeah, one of the ones. So that
Were they competing?
I'll come out and then just get a freezing cold.
I cool, sign me up.
Yeah. I'm considering doing the exam. For the hell of it.
How long do you get?
That's your
Do I want to do it, would you?
Come on, we'll be fine.
You got 5 days to finish 100 and something.
Well, I did the final stage in
You know that-
the small rucksack. I ran, and alright, it's a small stage, it's 15K. We'll be fine, I reckon it'll be fine.
David, you know that after the exam, you can come up with I don't know about doing this every year, just keep going.
So yeah, it was very picturesque, and this was what we were
Yeah, it looks
riding
amazing.
around in, so,
On a snowmobile.
yeah.
Actually, I'll do that. I'll do 180 Ks on a snowmobile.
I've done probably about
Yeah.
300 kilometres.
Yeah.
in a week on a snowmobile.
And you're keeping those pins.
No, that was our checkpoint, so that's what we'd set up at each location.
Where did you sleep? At a hotel?
No, in kind of cabins and things like that. It's kind of random.
Who's cold? Like, proper cold.
Well, you walk outside on the work. It was minus 36 at worst. You walk outside and your nose hairs very I stuck my camera to my face, put it that way.
Really?
My eyebrow hairs came off on my camera.
That's cold there.
It was cold.
I don't mind the cold so much. Like I'd rather be cold than too hot. Like if you had to send me to northern Sweden or the desert of Dubai, I would go to Sweden every day.
Yeah.
I hate being too hot.
This is the side of the lake where all the wind is blowing the ice, so it's starts to be really kept off the face. It's absolutely beautiful. And there's no one's out there apart from you, apart from that dude on the Dodge Lake.
Weather?
The weather
Very good.
So the first night, this is the beginning of the bad weather. You can see the snow come down. And that night we had, in that tent I showed you before, in my TP, that one that were in there, we had something like 14 people at 1 o'clock in the morning whilst having the mental health crisis going on in the tent. That we didn't know was a mental health crisis and no one had done something.
Did you know she had to make health back?
I mean, I'm not gonna lie, it's a pretty self-selecting group of people that go to have an ultramarathon in the.
I was going to say they all have a mental problem. It's just whether or not they're functional. or not.
If you look at the sort of the like human beings as a spectrum, the vast majority of people move away from inclement weather.
Yeah, well, it was
I saw a guy, like I saw a guy did his ACJ today, thinking he's an Ironman, or just training for his Ironman and stuff. Like, he's not even a professional. Like, he talks like he's a professional. It's like, oh, I've lost a whole season. It's like a whole season of doing an Ironman. Like, he's like, yeah, no, I was training for the Barcelona Ironman, no, and then I couldn't do it, and now I don't want to lose another year because it's still a little bit sore.
But look at the weather there. That's what the day started out with at airport at 1:30 in the morning the next morning. This is a different day, but that's how good it looked. And then at 1:30 in the morning the next day, we were evacuating that tent through the worst blizzard I've seen.
Really?
The guys, the Sami guys who were driving us around the bad weather were absolutely ace. This is their backcountry. They are reindeer herders. This is their backcountry. Absolutely is. So it's cool. So in the tent, you were sitting on reindeer hides, because they've got hollow heads. So you can put one down on the snow, you can sit on it, you do not feel the cold arse.
So they hold on to
Really
it.
good.
What, how much daylight do you get? The sun.
You got quite a lot. So that's Eric lying down on the snow.
He looks really cold, I'm not gonna lie.
He's got a salmon. He gave his gloves to one of the runners and came back in the blizzard with no gloves on. And he was like, wow. He just basically got frostbite in the whole of his hands.
Did you give away your gloves?
Because it was either him running into trouble and getting back quickly on his snow bike that has more handlebars, or the other guy running into real trouble. So he took the kind of better of the two bad decisions. He sacrificed things.
Yeah, how do you run in said conditions? Like,
So
what do you wear exactly?
I'll show you what guys are wearing. So if you see the
And do they actually run? Because the trails that are compacted.
The front four guys are running.
The rest of them
The
are.
rest of them are doing bits in
Jogs
between.
run.
Yeah.
Walks, runs.
There we go. So these lightweight racing snowshoes.
Okay.
when it's bad weather, but with the rest of it, the trails are deliberately compacted by the snow bikes.
I was gonna say, yeah.
So, because if you walk on it, you go up to your thigh in snow otherwise. So
Yeah.
there's about that much compacted snow on top. Problem is when you get onto the lakes, like we did on the last day, when it went from -36 on day 3 to +5 degrees on day 5. So you end up with surface melt on the lakes. So the lakes lose.
Water ski.
Yeah, pretty much. So you're going through that much snow into that much water onto the top of the ice, which is onto the lake. And the ice is like that, so you never can get through.
Yeah.
But the runners were forever getting wet.
Yeah, that's shit.
So, but they got used to it. They're all wearing sealskin waterproof socks and things.
Oh, those are amazing.
Have you worn them?
Sealskins, yeah. Those are
I've got sealskins, everything else apart from socks.
socks. I bought my dad a pair and he didn't, because he took him back to South Africa. It wasn't that cold, so they're amazing. They're really, really nice. Snow.
Yeah. Well, you need them. But like the guys at the front would be wearing, like that's their worst.
I can't be redone culture city this evening.
Timothy,
What's it?
come for a bit.
I've just got to pop to Brett's house and got some shit off, but then I'm probably going to head home because my wife's coming home. We haven't seen each other for 2 weeks. Sorry.
That old
That old chestnut.
chestnut.
How was the drinks at the Shakespeare last time?
I didn't go, I was up, but
Why was it moved?
because there was a wake, one of the regulars at the Cambridge day, kid died of leukemia, so they're holding the
Oh,
wake.
shit.
So I figured that the last thing they probably wanted was 15 orthopedic surgeons. They were like, yeah, it will delay you. You can come in like 6. And I was like,
No.
We'll come back next week.
Oh, that's fine.
Yeah, the front runners would be in leggings and like a long sleeve top and a couple of buffs, and they'd just be running.
See, I've always thought that doing one of those like dog sledding things would be
One
quite
of
fun. Yeah, as in like, that would be quite fun.
This guy was dude, he's German, but he spoke really good English. A cup of coffee in our tent.
Were they, what dogs are they?
They're his dogs. They're not kind of
Are they,
dangerous.
well,
huskies.
yeah, I was going to say, are they Mars or are they Sibes?
I don't know. He brought them from Germany with him. They're his house dogs. They're
His
just like
house dog.
Yeah.
They're like going for a run in northern Sweden.
Yeah.
Well, you on call next Thursday?
I don't know.
I don't know. That's my question. I don't have you.
How's the PR?
Yeah, almost on its last rites.
Really?
Yeah, it'll be pronounced dead fairly soon, I think.
I am on call next Thursday.
Well, how do you
Are you
mean?
all day or just
All day.
or at night? I mean,
Not nights. Nick is all night.
In what sense?
You're doing the night on the Wednesday.
no, it's changed.
Is it?
I stopped covered.
Yeah. You changed on Royce yet?
Yes.
You can pick that up.
Doesn't matter. It doesn't affect you.
In what sense is it dying? Like,
Yes, man. It's just Monday there wasn't a consultant.
And
On
Sam
call.
Hayes was on call.
Yeah, there wasn't a consultant on call. It's just a nightmare. Yeah, fucking nightmare. So what do you do on a Wednesday? You got full day theatre. It's not a Wednesday.
have they not replaced Mr. Wheel in terms of?
Yes.
There's a locum, yeah. But no, dude, it's not great.
How is Sally fitting?
I think it's okay. I don't know.
Let's come chat to it, see what we can do with the fellowship stuff. Wednesday, you're asking. Wednesday got elected. 'Cause it's,
What I'm basically getting at is which
what
day
day
is
can we meet?
can we meet up?
Tuesday?
Tuesday I've got 3 out of 4 I've got a 3-session day at Southmead. So on the 4th one,
Yeah.
is not a problem,
When's
but
the
that's 2 weeks time, so that's the 12th. But that might be good because if you're free on the 12th, no.
Well, I am free. I've got pre-weekend day. So we
Yeah.
meet up.
Why don't we meet up for an afternoon of coffee or even the morning? I don't know which is better for you. Morning's probably better for me.
Do you have the whole day off?
Whole day off.
Tuesday the
12th. And then we can open it up to anyone else who's free. We organise it and then just say
Okay.
10 o'clock. There's a really nice coffee shop around the corner from me that I go and sit and work at, that we can just take our laptops, get onto the Wi-Fi. I use my phone because it's just easier.
Yeah.
But get onto the Wi-Fi, go through some questions, start sort of seeing.
It's in the diary, isn't it? I'm going to do it. I can move back to Centre Park today before. Which should be fine.
But that gives you time to get up here. Are you happy doing it here? I can meet you somewhere halfway, maybe.
I will do it here. Next time we do it in another one.
Yeah.
Just not mix and match.
So I'll just meet Tim.
I'm easy again. I have to drive half an hour to get everywhere, so that's one way.
Yeah, no, I'm happy as well. It's just.
And then that's.
So we'll say 10 o'clock till whenever.
What's your next week after that looking like the 18th? I've got the Tuesday off again, but I expect you're working.
So the next week, yeah. So it's every. So I can tell you now which is my next one. The 9th of April. Next week, So yeah, we'll meet So then you done the
Just put the camera on it. Yeah, but I don't know how you attach it. You need to get a Gorilla Pod, and then you can just get it on a. I think I've got one. My mum's got one. Oh, and then plug it.
So you can just wrap that around the post, and then you attach a camera on top.
Yeah, that's part.
So it's got flexible feet. So instead of straight feet, you can basically wrap it around things, and you can secure a tripod to like poles. I think it's all one word.
Like
Yeah,
that?
like that. And then you wrap those feet round, and it can grip.
Oh, I just buy one of them. Do they work well?
Not used a huge amount, but a bit.
All right. Okay, well, we could be here a very long time, but I promise I'll keep this fairly short, because I think it's probably more interesting for you guys to go through the cases and case discussion. So, most of you are old. Any of you remember this place? Right, we're old here. That's the old AOC, and that's where the new
So that's your big unit that lasted less than the length of my consultant career. That's really quite disturbing.
And it had 5 theatres, and it worked, and we used to get 4 or 5 joints a day done in it. Oh.
Did it have anesthetic?
Did it have any? It had anesthetic.
Ah.
Anesthetic? Wonderful it was. Okay, so this is for a much bigger talk, and I'm not going to go in detail through all the slides because it's pointless. But I think it's useful to look at a few things. So sort of statistics around it. Don Juan fractures, calcaneal fractures were called. Why were they called that? Who was Don Juan? Jumping out the window. Yeah, he was a ladies' man, wasn't he? And he used to have to jump out the window occasionally, so that's where they got their name from. All right. So that's the sort of figures around it. So looking a bit at the history, I'm going to flip through these slides really quickly. But if there's anything you want to stop me at, do. So there's a lot of writing on these, but basically it's the history around calcaneal fractures and the fact that it's swung as it's still doing, and so many things do. In surgery now we should fix them, and then 2 years later, oh no, we've got to treat everything in plaster, and then oh no, we need to fix them again, and it's done this over the years. As Ian was, what were you saying, Ian, about the hitting things with mallets or yeah. So the original way of fixing calcaneal fractures, you put a wedge of wood underneath the foot. You pull down on the toes, you pull down on the heel, and you whacked it with a hammer or something. Well, I'm not sure much changed. But so this was 34 Westhouse, Jim. Does this look familiar? So where we almost sort of come full circle, going back to these now. We're doing the percutaneous things, Pete. We're sticking shanks pins in the back to pull things down and get the heel round into bearers. I'm not sure anything's new any longer. So I'll click through some of these. So I suppose this is worth stopping at. Yes, this is Presti, because you'll come across this. I'm sure you've all seen this. So this is the sort of tongue type that we see, and I would argue these are the ones that there's probably very little argument they should be fixed. Because if you see something like that on an X-ray, what's happening to the skin over here? It's under pressure. It's the same as the extruded talus under the skin. If you leave that, that's a true orthopedic emergency, and you've got to put those down. And these ones, by the way, were pretty well excluded from the calcaneal fracture trial. And of course, you've got the joint depression, and we'll come back onto that again in a minute. Okay, so as we've already said, or you've mentioned, really it's the advent of CT scanning with much of fracture work that's made a lot of difference to what we do. Also antibiotics, and as I said, the appreciation actually putting things back together in the right place probably has made things better. So, we've got ongoing arguments now as to what we do about it. The classification, I'm not going to go through that. You all know that the pictorial representation is probably better. This is what Ian was talking about earlier on with the ABC bit, where the fracture lines run and how many bits they're in, and so on.
Probably for the exam, no Essex Lopresti.
Essex Lopresti and this.
And
I think you need to know about it.
Pretty good idea about this, and then sort of ignore the rest of them.
I mean, you can look this up on that. Well, I'm deliberately rushing through this a bit.
Why this is relevant is there is evidence that it's related to prognosis.
Yeah.
So it's not just about the description of fracture patterns, it actually relates to prognosis.
And the examiners all know about this. It's one of the few things about foot and ankle they do know. Okay, so what about surgery? Well, I've got to mention this, haven't I, of course, because this is at the Bristol base. So this chap here, he got all the accolade for it, but it was this lady here that did all the work. And Greg was probably, what was he doing at the time?
Well, what predates it is that they did a randomised controlled trial in Leicester that Paul Gregg supervised.
Yeah.
And it was terrible trial,
yeah.
But that's why he was involved in this.
Yeah. Okay, so, and this did, I think, open people's eyes and start them thinking about fracture patterns and so on. And there's no doubt that a lot of good work went into it. So they looked at the various bits of the fracture pattern. As you see, the classic bit is the lateral wall fragment, then you've got the body fragment here, and then you've got the sustentacular fragment here, with that being the subtalar joint, talus, etc. So that's your basic fracture patterns. And they basically describe three types. And again, the examiners do know about this sort of thing, and you'd be expected to know about it. So type 1 is where you get your body fragment jammed up like a wedge between the lateral wall fragments and the sustentacular fragment. Okay? So it's straightforward. Type 2, the body fragment comes up towards and around, just starting to encroach on the lateral wall fragment, and then you've got the sustentacular fragment, which tends to be fairly constant, though not always, because like all fracture systems and classification, not everything fits into everyone every time. And then on the type 3, you've got the body fragment up around the lateral wall fragment. So when you go in on these, when you open them to do an open surgery, you can't see that because it's behind the lateral wall, which has been pushed up, or whichever way you want to look at it, the lateral wall fragment's been pushed down. So you need to know that sort of classification system. So the extended lateral, and this is, I think it's important, no matter what we're doing these days, to know how to do this, because if you can't work out what you have to do and get at something open and reduce the fracture, I think you've got very little chance of being able to do it percutaneously, even though that's the way things are swinging at the moment, before they may swing the other way, of course. So the extended lateral approach was popularised again by the same group, only instead of Paul Gregg, you've got George Lankheimer, God bless him, in the middle, who was a delightful chap and a very good surgeon. And they all described the extended lateral approach, which got around a lot of the wound problems of the direct lateral, which sort of basically carved through the neurovascular bundle, which supplied that bit of skin, which is one of the reasons the complication rates are so high. So in terms of how you deal with this is brief, I know, but you've got to get that wall out of the way, otherwise you can't see that. So you've got to pull it down, hinge it. It often comes off in your hand. Don't drop it on the floor because you've got to put it back in. All right. And once you've got that out of the way, you can see the lateral wall bit, which is basically the lateral side of the subtalar joint, and you've got to then get that back onto that. So you flop that down. You then this is very Neanderthal. It's good orthopedic surgery. Prof Atkins used to love it. So you basically jam a periosteal elevator or something in through the fracture site, underneath the sustentacular fragment, then you lever on it and you push down the body fragment. So you push it back out of the way and disimpact it. Otherwise, you can't move the other bits and get them where you want to do. Okay, and that's the lateral part of the posterior facet pulled out of the way. And once you've got this down and that out of the way, you can put that bit back in. All right, and this is just to say, if you get a sustentacular fracture, which, I mean, how often do we see it? And it's not as rare as you'd think, because that classification system, that constant sustentacular fragment is always in one piece. Well, it's not. And if it's split, it's a relatively easy approach between these two tendons to get at that segment, and you can put a screw in it. So don't be frightened about going medially if you need to. Okay, so the literature. So Pete wanted me to talk a bit about this, so I'll slow down a bit. So that like a lot of things in orthopedics, there's loads of publications over the years. A lot of them are small studies. The changes in trends over the years, it swings one way than the other. And at the moment, we're in a supposed non-operative phase of calc fractures because of a certain trial, which I'll come on to in a minute. Some for, some against fixation. Follow-up's often short. The trouble with a lot of trauma patients, a lot of patients are lost to follow-up. And there are so many variables in this patient group. So the papers you need to know about are probably Buckley's paper from Canada. Okay, that's the biggest study I think, Ian, isn't it? If I'm right, of all of these, 424 patients, and we had some questions. One of the multi-choice questions on this paper earlier on, and they came out with this conclusion that certain groups were better with surgery, certain groups were better without surgery. And then you might think this is obvious, but anatomic or near anatomic reduction gives you better results. What a surprise. Higher injuries or comminution is bad. Well, okay. But that's what that paper said. And then there's our good friend PH from Stockholm, who did another study, and he's an honest man, I think it's fair to say. And he went and looked at 82 patients, again split them down the middle, operated on some and operated on the other.
So this is the longest randomised follow-up study.
Yeah. So they've got a 8 to 12 year follow-up, which Buckley didn't do a long-term follow-up, did he? No. So this is a valuable paper again. And they again showed really no significant difference at 12 months with these fractures, which is essentially what the field trial has done, except they've got up to 2 years now. But there's a trend at 8 to 12 years to better outcomes in the operative group. And they've got a reduced prevalence of post-traumatic subtalar arthritis in the subgroup with a 41% risk reduction. And actually, a Buckley group showed similar reduction in need for subtalar fusion in the operative group. So that's the second big study. Okay, and then you've got, sorry, the resolution isn't right on this now. You've got the Coventry study, which is Damien Griffith's study. So the thing with that is that they started off with over 2,000 patients, and they did set the trial up, reasonably well as a randomised controlled trial. But
this is the UK.
This is the UK Hill trial. So by the time they whittled it down, they had 502, I think it was, patients that they considered eligible, and of those, 151 agreed to take part in the study. But essentially, they were looking at type 2 and type 3 fractures. And the other thing I think it's fair to say is that they were the only ones that were included were ones that the surgeon in question decided that definitely didn't necessarily need surgery, i.e. they fixed the ones that they would have fixed anyway and excluded them from the trial. So it's all a bit skewed. So they excluded the lateral wall blowouts, they excluded fibular impingement, they didn't look at all at extra-articular fractures, and if you look at the figures, there were 22 centres, so with 151 patients, that means a mean of 7 cases each. So if you split that in half into the operated group, they operated over 2 years on three and a half patients. So
lots of surgeons did 1 or 2, didn't
yeah, so I'm arguing if you're doing that number, maybe that partially explains why your complication rate is so high. So 23% of the surgical group had complications, 19% were infections. Now, we've done open fractures here, including the guys down at the BRI for years, and we're nowhere near that. So I don't know quite what they were doing, but maybe that's an indication of the fact that they weren't particularly experienced at the surgery. And then they followed them up for 24 months. But the conclusion was that there was no difference between the operative and non-operative group.
So one of the additional factors in the power of this study is that the power was insufficient to look at the infected group post surgery as a separate group from the operative group. So, in other words, infections probably influenced the results of the operative group, but you couldn't show that they had influenced the results of the operative group. So there are lots of flaws and problems with this study.
Okay, so I mean, Ian's been through some. I'm not going to pontificate too much on this. We've got a lot of other things to get through. Okay, anecdotal bit. Quite often, if we feel stuff does better with surgery, we're right, even if you can't necessarily prove it with a trial. Not always, of course. So I've just got a couple of short cases to finish off with before we let Ian loose. So this is a calc fracture of sorts with a fibular fracture associated. I mean, how many of you would treat that conservatively? The Hill trial says we should. You can't operate on calcaneal fractures, isn't it? How many of you would treat that conservatively? How many of you would operate on it? What are the others going to do? Okay, so I would argue there are groups of fractures.
You get a very skewed view on calcaneal fractures in the Bristol region because of the history. So the BRI fixed them all. Most of the people regionally have been trained by here in the BRI. We fix them percutaneously, they fix them. Everywhere else in the country is basically putting them in plaster now.
Yeah.
So just be very aware of that when you go up to the exam. It would be very sensible to say, I would treat this non-operatively as per the UK Hill fracture trial.
Well,
unless you feel very confident.
You've got to look at the group they're looking at, though. So if you're looking at type 3 or type 2 or type 3 with relatively little displacement, then I think it's perfectly reasonable to stick them in a plaster.
Yeah.
But they're probably not the ones we would have operated on anyway.
So there's a very good review article where Buckley's the first author in Foot and Ankle Surgery. I think it's about 2.5, 3 years old now, which does a very good review of the whole subject. Partly because I was the co-author.
All right, so I think most of us would try and reduce to fix that, because that's the lateral part of the posterior facet up there underneath the fibula, which is what's not the end of it. And that's also pressing on the skin. That's just subcutaneous. So this thing is dislocated as well as displaced. And I think most people would fix that, which is what we duly did. And we got a half decent outcome, I would argue, there. So I'll briefly mention this. I mean, we're doing a lot of files, well, virtually all of ours now percutaneously. So when we started doing this, or when there's a group ship, I think it was I first started talking about this with a guy from Australia, everyone thought we were nuts. But there's no doubt with these that you can fix a lot of them percutaneously, and that subtalar part of the joint is pushed down. So what you can do is get under that through a stab incision in the lateral wall, get a periosteal elevator under it and lift it up. And then to add a bit of spice to it, because we like sticking scopes and everything, you can stick a scope in the subtalar joint and watch it come up. Great fun. And then you can get that sort of result. And how the pattern, there's various patterns of screws you can use to fix these, and I'm not going to go into detail because that's a whole talk in its own right. But we've been doing these now for probably the last, 7 years here? 8 years? Virtually all, not all, we occasionally open them now, but with a reasonable amount of success. And that's something we need to review, of course, before we can really
So there are now series coming out all over the world of percutaneous approaches. And of course, the key thing is that 19% infection rate. So locally in North Bristol, the only ones that we've seen with infected problems afterwards were the open ones where you would have predicted it anyhow. Had no
form of infection related to closed fractures at all.
Well, the biggest problem doing it, because Pete, I know you know, is getting the heel out of varus.
So the big problems of these fractures are that the heel goes into varus, that then locks your whole foot in varus and restricts the movement, and your loss of height and secondary blowouts and calcaneofibular impingement. So that's why these treatments are very powerful. So you can squash it up, prevent the impingement, and get it out of varus, and then hopefully prevent secondary problems. And then the only subsequent operation you hopefully need to do is a subtalar fusion.
So you get the shape right, you get the height right, you get the varus valgus right, and then you've got something to play with in the future if it goes pear shaped. Can I show that? So can you click on that on the computer? So this is a subtalar arthroscopy in an ankle fracture. And you think, oh, you can't get in, you can't see what you're doing. Well, there's a bloody great hole there, you can drop into it. Dead easy. So it probably doesn't project very well. So that's your underneath of your talus, that's the posterior facet. That's down the side of the, looking down the side of the posterior facet, looking across the joint, you can see the fracture line. So this is a fairly straightforward two-part. And if you watch that, we're getting underneath it with the periosteal elevator, wiggling it around. There's a bit of fiddling and jiggling going on. It's great fun. Mm-hmm. And with these, once you've got it reduced, and you can see you've got it reduced, you just fire a percutaneous screw across from lateral to medial as you would do for a standard fixation. Here she comes. Pete didn't believe me till we did a couple of these. He's still not sure. There we go. And you can just watch your reduction. All right. Yeah. Okay. Okay, I'll leave it at that. Thank you.
So top right hand corner, you have your screen up. You have to arrange it at the top.
I think it's that bit.
Okay. Probably best.
That'll do.
Okay. So, okay, fine, this is quite a lengthy presentation. I'm not going to show you all of it. Really, what are we looking at is talar fractures? What are we trying to plan for? What are the complications that happen? So I'm not going to talk about peripheral fractures, but I am going to talk about neck and body fractures. So what we all know is that you've got three major joints involved. You've got complex blood supply, and that's inevitable that if you have injuries, then you're going to damage 3 joints and you're possibly going to damage bone as well. This is really quite irritating. Isn't it? I wonder what happens if I try and do one. It's not going to work, is it? What's suggesting when you come
So
in?
if you go back to the main screen,
Yeah.
close that, go back to your settings for your screens.
I thought we'd done this one.
So yeah, the middle tab should give you the, using the Wi-Fi that I was talking about.
So, which one?
So if you minimise PowerPoint.
You can't see it from there because it's.
And then on that one, the top 3 tabs, I can't see, but they're there, the middle one.
That says colour.
You both come down.
I think it's the interaction between
There's been a bit of communication about something which school were a bit reluctant initially. Yeah, no, it's not going to be from, not supposed to be from, it's meant to just leave a canister outside. Officially, it's from the dean, yeah.
Still does it.
So anyhow. Quick interruption.
Drag it across.
it's in there.
If you drag the PowerPoint to this, it's a separate ordinary.
Controls.
So, anyhow, the complexity of the flow supply means that no matter which approach you use, you're always going to have a degree of risk. But the so-called medial and lateral utility incisions that you can extend all the way down the foot give you the best access with the least vascular damage. And so there's sort of element of controversy is, do you fix at the level of the neck, or do you fix outside that, particularly posteriorly to anteriorly? And there are pros and cons of all of it. So this is what we were talking about earlier on. So if you have a significantly displaced fracture, what you have is a medical emergency of the soft tissues. Now, having been a little bit coy about Professor Atkins early on, in relationship to calcaneal fractures, what Roger comes up with is a phrase called social reduction. And what he actually means by that is, if you've got a fracture like this in the middle of the night, you don't want to be up all night struggling with it. So the principle is that you have to take pressure off the soft tissues, and you have to therefore primarily reduce the body into a decent position. And to do that, you need to often put on a distractor of some sort, and then you can reduce it. If necessary, you need to make an open incision to do that, but you can do it closed. And once you've got the body back in the right position, the fact that the fracture isn't necessarily in the right position doesn't matter, because then you can plan your care subsequently. Now, if you're somebody who has a peculiar interest in this, you might choose to do that on the flow through a weekend of being on call, but you've got to take care of the soft tissues. Now, the trouble is, I can't see it on the screen. So that's the issue of the social reduction, trying to make sure that you've got a definitive plan and reduce all of the joints properly right from the start. Oops, hang on a minute. There we go. So that's an example of just getting it primarily reduced, and then you've got time. You don't have to do anything about it. And that's contemporary teaching, social reduction early, and then plan your definitive treatment. Every one of these cases should have a CT scan, and it comes under that phrase. The more you scan, the more you see. And okay, fine, we've been through this, but for the exam, you definitely need to know the Hawkins classification. It's unfortunately
So my computer's not going to work again.
Yeah.
Mr. Harris has sabotaged me. So the Hawkins classification, everybody knows about, everybody talks about, but knowing the history of where that paper came from, there's very small numbers of cases. The treatment was not standardized in any straightforward form. So the consequence of it was not inconsiderable. This is such all of us international speakers are so professional at all of this, aren't we? I'll tell you what, why don't we go back to doing some cases at the moment, and let's sort this out in the background. Do you want to do that?
Mm-hmm.
Because this is driving me nuts. We'll go back to that. Can you do it on here? No, they're going on here. It's not all over. Yeah, that's what's going on. Yeah, it's an interactive. So the debating way is, how do you fix them? And there's basically two methods, really. There's fixing them remotely by using something like posterior lateral approach and using screws, or fixing them directly by doing a combined approach, usually a combined approach. Theoretically, you can get away with a single medial or lateral approach in some of them, but most of them need a dual approach. And the aim of the exercise is very simple: get all of the joints reduced and get the fracture stable and fixed. So this is the sort of difficulty when you've got relatively, once reduced, stable fractures. But placing those screws can be quite difficult to do. And most commonly, the error that's made is that you get the angle and the position of the fixation wrong, usually too high, and that produces an angular deformity. So that is quite low, yeah, and that's doing it from back to front, and it looks quite good. If you fixed it from front to back just with screws, the argument is that maybe you open it up on the subtalar side of things. But of course, when you actually look at the CT scan and recognize that the fracture patterns aren't absolutely linear, then things become much more complex. And that's where you need more accuracy reduction. What's the commonest deformity you see with a talar neck fracture? So the commonest thing that happens is they go into varus. So rather bizarrely, with a fracture that should theoretically destabilize the whole foot and ankle and make it flatter, because that's the stability position, it's a flatter foot. Because you get a varus deformity, you end up with a calar varus foot, which is a bad foot because it's stiff. And this is the sort of thing that can happen with when you use posterior approach, is if you get the screws in the wrong place, you can get angular deformity and you don't control the varus deformity as well. And so most people these days would tend towards advocating direct approaches and reduce the fracture with good soft tissue handling. Okay. So that's the medial utility incision extension over the medial malleolus, tib ankle at the front, tib post at the back. And relatively, you've got at risk, a low risk of vascular damage. Lateral side, got to be careful about the sinus tarsi, because that has quite a significant component of the blood supply. But again, you can plan your incision in a relatively low vascular arcade position and get to both sides that way. So we tend to have this idea, we look at Hawkins 2, that's a Hawkins 2 fracture, but when you look at it on a CT, what is it? You know, that isn't in the Hawkins classification. And that's what we did with that. So combined approach, all the fragments reduced, 2 years down the line, 3 years down the line. It's an open fractured talus. Again, look at the CT and think, oh, that's horrible. More a body fracture than it is a neck fracture. But again, so despite being an open fracture, 18 months down the line, reconstructed, it looks reasonably good. In fact, you start to wonder about the AVN component of it. There's the index of suspicion. So what's happened here? This is a child. Anybody see any fractures? Those of you who've worked in North Bristol should be saying, oh, it's a coalition, because everything's got a coalition. Can you see any fractures? Bill's seen this before, so. So there is something happening in the body of the talus, isn't there? And you would say, okay, there's something there, but it doesn't look terribly. You know, is anything really displaced or anything really in trouble? And then you look at below the medial malleolus and you think, hang on a minute, there's a bit of bulgy bone there. That's what the CT shows. So the index of suspicion with any major hindfoot trauma to do a CT should be low. So you look at plain X-ray, you think, that looks a bit funny, I'm going to do a CT. And we've seen that with the Lisfranc, we've seen it with the Celts, we've seen it with injuries to the talus. Guys, bad injury. Fortunately, being relatively young, they seem to do quite well. So actually, AVN is probably much lower than the original Hawkins figures. So most series now, the maximum rate of AVN, if you take out the Hawkins 4s, is 25%. So it's lower. And part of the reason for that, of course, now we've got MRI, we can be more critically analytic of it, and segmental AVN is probably commoner. So if you look at an MRI, you can see little patches of AVN, but the whole body of the talus is relatively vascular. Non-union rates around about 2.5%. So, trick question, if you have a non-union, can you have early AVN and collapse? Pete's looking up at the sky. So what's a criteria to get collapse of the talus early if you've had avascularity? What do you need? So test the question really, why do you get AVN? So the AV bit makes absolute sense, cut off the blood supply. The N is necrosis. Why do you get necrosis? Why do you get collapse of the talus? Well, in any AVN situation, why does the bone collapse?
It's part of the healing process to get inflammation and absorption by the bacteria.
Okay, so that requires a blood supply. So how AVN works is you have a dead piece of bone, you have a healing reaction going into that bone, you have a wave of revascularization going through that bone, and at the point it's revascularized, bone is reabsorbed. So the structure of the bone is destroyed as part of the healing process, and then it's like, it's like watching a machine go through something and lay something behind it. So it gobbles it up, puts bone behind it. But in doing so, it makes it mechanically unsound, collapses. Yeah. The only other way is late AVN, where there's never been any process of revascularization, and the effects of multiple impacts through the bone, eventually it just mechanically collapses, disappears, or the structure disappears. So the answer to that question is, if you have non-union, you cannot have early AVN because there's no vascular supply, because there's not been union. Yeah? So in a non-union, the risk you run by revascularizing the bone by getting union is that you could induce AVN. Yeah? So that's a worthy thought. Let's just go on the wrong way. So that's the definition of AVN. And of course, multiple causes of AVN. It's not just trauma. Okay, I'm just going to go through things a little bit. So it doesn't actually show that well, which is slightly disappointing, because this is a case of AVN. And of course, we all talk about Hawkins sign, but what's the sign of avascular necrosis or avascularity? So in that very first set of questions, there was generalized osteopenia as being one of the potential answers. Is that a good question to ask? It's an excellent question to ask, because how do we get post-traumatic osteopenia? What's a prerequisite for having osteopenia? Blood supply. So if you've got generalized osteopenia, if the talar body is exactly the same amount of osteopenia as the distal tibia through post-trauma disuse, you've got vascularity. Yeah? And that, Hawkins never said anything about that. His signs were much more subtle than that. So the opposite is true. If you've got avascularity, what you see is radiodensity. You see apparent sclerosis compared with all of the bone activity. So if you see that, you're in trouble. Yeah. Oh, actually, it's next time. There you go. So that's clearly sclerotic. Everything else, a bit osteopenic around it, but that bit is probably dead. Yeah. So that is the opposite. What we're looking for, we're hoping for, is positive Hawkins sign. If you see this, you're in trouble. And it's, look at it on a CT and it's all the more obvious. It's clearly a very dense piece of bone when it should have absorbed. There is a bit of an argument when we were looking at this, we said it's also infected, but that's an aside, because it's those little erosions around. Okay. So you can get spontaneous AVN as well. So this is one of my favourite stories ever. So this 36-year-old Clifton coach, just retired from rugby, comes with just non-specific but deep-seated and very troublesome hindfoot pain. MRI scan shows AVN, and so what we did with him was we put the vascularized fibular graft, and it's a message: never ever trust a plastic surgeon, because I made a beautiful trough into the neck of his talus, into the body of the talus, for them to slip the fibular graft in, give the talus structural support and the new blood supply. And what do? They stuck it in like sticking a stick into a hole, because I got bored and left. Fortunately, rather strangely, it actually revascularized. So we don't know when you do a curettage and a debridement in that way why people revascularize. And it may well be a decompression phenomenon. We see that around the femoral head, and it applies to the talus as well. So, yeah, okay, fine. So how did we manage that? We had a very good chat with the patient, who was very understanding, and I'm eternally grateful to him. And around about 2 years out, we did the most bizarre arthroscopic decompression of his anterior impingement. And he said, oh, that feels better, and carried on coaching. So never trust them. There's a concept of what is involved in an avascular process. And this sort of number of joints involved, some bone, all bone. So using an MRI scan, you can say, is this total AVN or is it patchy AVN? And the vast majority of them, particularly post-trauma, are actually patchy AVN. The downside we have is that AVN most affects the talar dome. The most catastrophic effect of a talar fracture is on the subtalar joint. So you stand a reasonable chance of losing both joints. But if you critically analyse where the problem is, then you can plan your care. And one of the ways of revascularising a sunbone AVN is actually to fuse either the subtalar joint and introduce a blood supply from a big healthy bone graft called the calcaneum, or to do an ankle fusion and use the tibia to revascularise the talus. So relatively early intervention, if you've got avascularity, accepting that the joint is going to go, and using a fusion to revascularise the area is a worthy strategy. And as I say, using this sort of concept of how many joints are involved, how much of the bone is involved, allows you to plan what you're going to do. And you can see that's another case where you can use a subtalar fusion to revascularise an area as well. And then you get both joints.
Nail gun out.
Yeah. And you start to smile because it's got genuine metalwork in it. And there you can see the central segment is actually looking relatively sclerotic, but the general shape of the hindfoot is preserved. And then you get all sorts of other things to do. So if you're managing something like this, you have to think slow, you have to allow things to revascularize, you need to protect them for long periods of time, and so forth. And in summary, that's how we think about AVN.
In the talus fractures, there's always the debate whether you do 1 or 2 incisions, and I think increasingly people say you should use 2 incisions because it's very hard. It's like doing a 3D jigsaw puzzle. It's very hard to judge your reduction from 1 incision. And you think you've got it, even if you've got it open on both, it's really hard. You think you've got it perfect on one side, and the other side doesn't look right. And often it's because as it's collapsed into varus, it's squashed and crunched the medial walls. So quite often that side has to be jacked out.
That's the difficult bit. If you jump it from the back, you can't judge how much to push.
So we've actually seen people who have had varus malreductions through a single incision when the surgeon has actually referred them saying, I think I got the reduction perfect, and they've actually got it rotated 90 degrees. So it's really easy to do through 1 incision, but you get a malreduction. So I think 2 incisions doesn't seem to make any difference. When you look at the contemporary figures for AVN, then where's the evidence by doing two decisions, which is very contemporary practice, that we're increasing the rate of AVM? We don't appear to be doing that. So getting a good reduction is the key to it. And at the end of the day, the AVM is probably determined by the moment of injury as much as anything else. And what we mustn't do is produce malunion, because then you've got a good foot round it. And if you've got AVM and a healthy foot round it, your management is so much easier.
Right, should we do some cases?
Yeah.
So, 64-year-old type 1 diabetic, ankle fracture in another hospital, May 2018. Tim, what have you got over?
APL lateral radiographs of right ankle demonstrating fracture to the fibula. It looks like it's oblique. It goes from anterior inferior to posterior superior. Looks like the posterior malleolus is off the tibia as well.
Yeah. Okay. So what's your initial management?
Confirm this is an isolated injury. So they were type 1 diabetic on the first page, so that's not going to affect my initial management. But initial management will be to reduce this, confirm neovascular status, hold it in the cast, get some repeat films, and we've got a posterior malleolar fracture. So if this is an isolated injury, then move on to a CT scan.
So that's our initial reduction. So luckily they did it again. Okay. You can see the posterior mal fracture there nicely. So 64-year-old type 1 diabetic peripheral neuropathy. So treatment.
Let's know a bit more about them. Yeah, HbA1c.
So they've all got high. So HbA1c is 90.
So treatment, you can manage this one of two ways in the discussion with the patient. According to the Ames trials, you can manage to either in a close contact cast, which needs to be applied in case I said before, or you could primarily fix this. And then methods of fixation discussed with the patient be open reduction and fixation. I would, he's diabetic 61. If we think that posterior malframing is crucial to fixation, and to fix that, if we're not convinced it is, then we fix the fibula and fix the rest.
That was initial. So you're worried about stability here, aren't you? But actually, you've got quite a good reduction. So show of hands, who's going to manage this in a close contact cast, and who's going to fix it? Close contact cast? Yeah. Fixation? Okay, good. Is anyone going to do that? Is that adequate fixation for a diabetic? So poor skin, so they've tried to do something percutaneous. You look very closely. I don't think the fibular nail is actually in the tip of the fibula. Yeah. AP looks quite nice. So that's there. And then this is a couple of weeks down the line. Or maybe this is 6 weeks or something. So that's what happens like then. So what are you going to do now, Damien?
Well, again, take a full history, examine the patient. What's the skin like?
Skin's okay.
Any signs of infection?
No.
So clearly it's failed because of inappropriate or not adequate stability in the fracture. How long down the line are we now?
6 weeks.
6 weeks. I'd want to know what the symptoms of the patient are. Presumably he's been walking on this. Is it painful?
So he's neuropathic.
So
That may be the problem. He has no symptoms.
yeah. I mean, his biggest risk now is, I'd worry more about the skin with this. If he's not in pain, he'll walk on this and he'll eventually erode through the skin. You need to stabilize this. If we can reduce it, you could go back to what we initially thought we could do as a cast for an extended period of time, or provide him with stability infused in the ankle, which will provide him stability, and then but you had an increased chance of infection, given that this will be a second surgery in a very short space of time in a diabetic.
So most people are going to revise it?
No, I'm for now.
I'm for now. What's Mr. Winston going to do?
Probably would want to put on for that.
Yeah.
But this is not now an ankle fracture. What is it?
Chronic dislocation, the soft tissue injury.
No, it's involving Charcot.
Charcot.
That's what it is. Because you've got a neuropathic patient who lost control, and we're being critical of that fixation. But if you put them in plaster, then maybe they would be better off, because maybe you would be able to keep control of the patient. So the problem here is they've done minimal fixation, and the patient thought, oh, I'm fine, and I can wander around on the
There was a lot of the problems with compliance.
So compliance is a huge issue. So this patient is now behaving like a Charcot patient. They don't know that there's a problem because they wouldn't have presented with an X-ray like that.
So just in the interest of going through, so we had it fixed. I presume it once looked better than that. I imagine the post-operative films look good. It did, yeah. A few people have seen it. So unfortunately, I haven't got the immediate post-operative films, but this is when it got referred to Southmead. So that's a reasonable thing to have done. So they put something rigid in there. I think most of us would have done a home foot now at that stage, but it's very easy to make that decision with the retrospective scope. That's what it would look like in clinic at some stage. And then 10 days later, it still looked like that, but worse. And there was a medial wound. And so when it came across to us, it was pretty impressive. CT angiogram showed no reconstructive options, so he got an amputation. But they're high-risk patients anyway. So I think if you've got compliance is an issue with these patients, you've got to, whatever you do, be very, very careful with your immobilisation. And I think these ones do quite well with something strong and rigid in the middle to start with.
Well, I think to take it one stage further, by the interviews, but you could almost make an argument with these for doing a primary ankle fusion. First off, a formal takedown of arthroscopic fusion.
Go back to the first bad X-ray.
What pre?
No, after that.
That one.
So if you're in the exam and you're confronted with that, what are you going to say? What's your opening statement going to be?
This is a limb-threatening injury.
You're going to say, this is a limb-threatening injury. Have any of you coming up to the exam actually managed something directly like this?
No, you'd refer it to your specialist.
You're going to say it's a limb-threatening injury. I am going to have a conversation with the patient, and I'm going to refer them to a centre that manages these problems on a regular basis. But I would then expect them to do one of the options. And okay, fine, you can choose all sorts of different options there. But it is one of those scenarios where you don't want to see that, and you want a high level of expertise sorting it out. At that stage, you don't want to get into secondary problems.
I think the application needs to be mentioned very, very early on, because it always comes in at the last minute. We all know that there's a risk of amputation with that sort of thing in a diabetic.
I think with a lot of these, there isn't a correct answer. They just want, in life and for the exam, which is the next immediate hurdle, we just want to say something sensible. So 29-year-old, apparently recreational drug use, jumped from a window, presents with this injury. So John, what can you see?
So this is a PA radiograph of a left calcaneus and a lateral ankle radiograph, which shows an intra-articular comminuted calcaneal fracture. There's loss of height and shape with involvement of the subtalar joints, and it's currently subluxed.
Good. So actually this one's not awful, but typically on this axial view, you see the heel swings into varus. It's a little bit varus here. As you say, complete loss of Bowler's angle, and so it's completely flattened. So management plan.
So take a history, examine the patient, make sure it is an isolated injury, assuming it's isolated, closed and neurovascularly intact. If he was a patient who was compliant and a surgical candidate, I discuss operative management, which could be either an open reduction, an internal fixation, by a direct lateral approach, or percutaneous fixation.
Okay. I think that's very reasonable. Did you do a CT scan?
I would preoperatively.
You wouldn't?
I would.
You would, yeah. So just to see it. I'll switch up, I don't know what I said.
So let's just touch on an area of difficulty while looking through that. So
At that stage, while you're thinking about your CT scan, look at them and you think they've got a foot compartment syndrome. What are you going to do at that point?
So compartment syndrome is an emergent condition which should be discussed with consultant on call. If I was the consultant on call, there's an argument for reducing morbidity irrespective of what you do, and there are some schools of thought that managing the compartment syndrome with a foot block in the first instance and treating the residual claw toes is a less morbid procedure than decompressing it. But a compartment syndrome should be considered for emergent decompression.
So I'm going to do the aggressive foot and ankle thing to you now. Sorting out post-traumatic claw toes is no joke. It's bloody horrible. They just, you straighten their toes and the clawing comes back. It's a nightmare. So is there anything that makes sense? There's two things that you have to watch out for. So there's this huge debate about compartment syndrome in the foot. And there's a definite and appropriate school of thought that says that if you decompress the compartments, all you're doing is turning a closed fracture into an open fracture. And therefore, it's illogical and hence just go with the claw toes. But there is actually a randomized controlled trial out there that shows what you do, take the plaster off, put an ice compression device on there, cool the limb down, squeeze on it, get rid of the swelling as much as you can, and you're probably doing them a favour by doing that. You're reducing their morbidity without adding to their morbidity. So there is an RCT that shows that. The one time that you definitely decompress this is if they happen to have a come-off based compartment syndrome and the foot compartment syndrome at the same time, because their prognosis is bad. They get horrible contractions. So that's a different scenario. So one of the things you can say, well, the first thing I want to know if they've got a foot compartment, have they got a calf compartment syndrome? And you're taking your conversation, particularly for the exam, onto a higher level. You've already said, oh, I know there's a debate about foot compartments, but I know what the really risk factor is when you've got more going on higher up the leg. Yeah.
So if you're decompressing the leg compartment syndrome, do you have to decompress the foot compartment syndrome, or can you manage that as a separate entity?
That if you're doing a proper decompression higher up, that you decompress the foot. Yeah. So by the time you particularly it's the deep compartment that gets affected. By the time you've opened up that properly, actually, you've opened up down the line of FHL. Down the line of FHL goes all the way through the foot. Stuff comes out.
Is there a higher, if you leave these loans, is there a high amputation rate? Because you're not just.
So what happens with the deep compartment syndrome, the combined on both calf and foot, is you get an equinus contractor into varus, because basically they contract along the line of their FHL. And the only way of dealing with that is to do an FHL excision. You have to take out the whole compartment to release them. It's a horrible deformity. It's rare. That's what it's wrong.
They'll be at risk if you don't decompress.
So it's
sensate foot movements.
Yeah, so there's the contracture, leg contracture, there's the business about sensation. Yeah, it makes absolute sense to decompress them in the calf, but it doesn't make sense to decompress them in the foot. As I say, rest, ice, compressive devices, all of those things are going to help. If you've got a really badly displaced fracture, you can actually manipulate the fractures and they'll reduce to some extent, and you're probably taking pressure off them. But it's probably better to do that than open up the foot and turn it into an open fracture.
In reality, what compressive device would that be? Foot pumps?
Yeah, you can. Well, the ice compression pumps are the ideal things. The ones where you put water into them that's been iced. That's what the trial was.
They've got them on the elective wards.
They've got them on the elective wards.
So this is a straightforward Sanders 2, just about here. You see that split in the middle. So you could probably argue this guy do reasonably well, non-operatively treated, but it's also it's pretty straightforward to reduce, and you see you can restore the height. This screw goes across, squeezing the two together,
We've got to get that body fragment out of the way first.
And the body fragment you pull down and slightly over there, so we've got a reasonable shape here. And that's done through 3 small incisions, well, yeah, 2 or 3 small incisions. Okay. So 83, residential home, doesn't walk, peripheral neuropathy, diabetic, high operative risk, morbidly obese, open ankle fracture, this time they're almost certainly almost not commonly medial wounds, but this time an 8 centimetre lateral wound. And presents with this injury. Says, I've got another. He's fat-legged, so it's quite hard to get a good actually.
Can you go back to?
We've got another one. That's all the extras we've got. So,
So what sort of fracture is it, sir?
It looks like a distal tibial.
Yeah, it's pelon, isn't it? It's
Yeah.
not an ankle.
so it's gone out the
It's
back.
the same as the one we saw earlier on. He's a bit older.
We've done some work across this a good bit there. Got some sort of vertical medial fracture there. So it's an open fracture. So he comes through here, he gets the usual first stage debridement. So he gets the 5 litres, he gets the wound excised. But everyone's a bit worried about him, so we don't really do very much wound excision. Give it a good washout. And he gets a CT angiogram, so they all get that. And he hasn't got any flap options. So what are our options for him now?
How big was the wound against?
8 centimetres. It's a sort of transverse split really that's had a bit of a nibble around the edges to excise the wound.
I mean, it's one they could consider, I suppose. I think it's again one that you'd want to probably do some form of fusions, whether it be a hindfoot nail, and then reconstructive wise, they couldn't even do a medial plantar flap. Is that
So
one?
well, it's a lateral wound, so you haven't got a local flap option.
So you can either think about covering something with soft tissues, which in this guy is going to be very difficult because your options are limited. So if you can't add soft tissue in, what else can you do?
Take bone away.
Yeah. So this guy gets an amputation or an acute shortening. So we went in, cut the fibula out, chopped the top of his talus off and the bottom of his tibia off and stuck a hindfoot nail up. And then I was very sad to hear that when he came back to clinic and he was very infected and treated with antibiotics for ages. But that's subsequently gone on to unite and is now off antibiotics.
I think that's worth pointing out because everyone thinks that's all nightmare. And we've had a few of these where we've known they've been infected and fallen apart. We take the original fixation out, put a nail in through what we know is an infected field. But we stabilised it, got the skin healed, treated with antibiotics, and they do heal. They don't all go on to amputation.
Yeah, this guy can be treated with suppressive antibiotics if he flares up again for the rest of his life. It's metalwork. No metalwork stayed in, but if he comes back, that's something you could think about.
Of course, the medical microbiologists hate it. They hate the fact that we've got metalwork in there. So
there's Andy Riddick's got a lot of cases he's treated with acute shortening. Open mid-shaft tibial fractures, you can chop a huge segment out and they walk around 10 centimetres. Well, they don't often walk, but at least they've got something that's closed and healed and not infected.
But these guys don't even notice the height loss.
Yeah.
And you can turn what's potentially a terrible situation in terms of getting the wound closed into something which you can put non-tension sutures in and they heal up.
Khaled, 37-year-old lady, usual sort of history of ankle fracture, fitting well normally. I haven't got, I'm afraid, a pre-cast X-ray, but what can you see there?
With an AP and lateral left ankle and a back slap really. It's like one of the ankle fracture that is reduced to the posteromalleus associated with it.
So posteromalleus are fairly obvious here.
Can't see anything on the medial side.
Yeah, I don't think I can see anything on the video, so. So we've got some CTs. Coming in from the medial side, you see this fracture going all the way across.
Yeah, so that's a significant postural fracture that's common to diaphragm fragment I can see. So probably, so this this I would fix through a posterolateral approach, and you can get fairly medial with that as well. And then you can put an antibiotic in the video as well, in addition to that, which will stabilize the ankle joint.
Good. So the only other thing to say on her, so that's the thing back here. So she's got this white stuff fragment just there. So that was a slight problem to get to. Yeah, I think that's a very reasonable thing. Could make an argument. So we've got no evidence.
Kelly would go posterior.
Yeah, so you could go posterior medial along, or on the medial side of the TA, or on the lateral side, and you can get to probably everything you need to. You could make an argument to leave the posterior mouth. I've just told you to fix them all, but if you get back to her, she's got the mortise is under the tibia. So actually, we've got no evidence that fixing the posterior mouth is going to change your outcome, although we think it's a better idea. So you'll get plenty of people who will ignore that and just fix it. But I think mostly here we would fix that. So
If you are going to fix them from the back, then we would get them going more aggressively. So we know if you're sticking in plaster for 6 weeks, everything else sticks. So you get them weight bearing once the soft tissues have declared themselves.
Would you consider an anterior approach over the syndesmosis for that wax stuff?
yes, I think if you can't get it out and reduced, you can.
Would that be the reason why you start posterior immediately? So that it gives you the option to an anterolateral incision as well.
Yeah.
So it's skin bridge.
But actually, even if you're on the lateral border of the TA, your skin bridge is still.
That's where the standard teaching is. So you
you get more.
if you're going to do it, you go right side on the ends. And if you need to, you can have an anterolateral or lateral incision as well, because the skin bridge is big enough.
Yeah.
And if you go across immediately, you've got even bigger.
Yeah, well, that was our philosophy.
This was done on the lateral border of the TA, and you can get right the way across if you need to. You see how far that T-plate goes. When you're putting these T-plates on, you've got to really contour them. So they're designed to go on the wrist, so you've got to bend them the other way, but the limbs of the T, you've got to really bend around, because otherwise they are proud. And the biggest problem with this approach is the mobility, because the FHL gets really stuck down, so you've got to get them moving their big toe straight away. But this should be a solid reduction, and you can weight bear them immediately.
Yeah, the biggest mistake people make is they do all of this thinking, oh, we'll make them stable, and then they don't take advantage of that stability, which is movement.
Good. And then that's what she looks like down the line. So she's okay, I think she's for some reason well. She's like if you're an American now, she's done great. Where she's back to high level sport, and back to the
American, they all run marathons within 6 years.
In Bristol, they go free.
So Andy, 57-year-old male, hit by a car, spitting loud. Sorry. This injury.
So you've got an APL lateral of the ankle with a incongruent joint with a laterally displaced tendons. So that's on the line. There is something tibial with that, and there's something just at the top of the X-ray. I'd like for tibial to the view and talk to the views.
I don't think I've got those. Maybe I have. Yeah. So there was a fracture there.
Okay.
So management plan to him.
So you told me it's an isolated injury, which is a high energy injury, ACLS guidelines. But in this case, you want to reduce and hold, which hasn't been done, so I'll reduce that again. Get it back in joint and then plan for surgical fixation of the concern that there's going to be syndesmosis injury here. If we can reduce it.
Are you concerned there's a syndesmosis?
There is a syndesmosis injury. My concerns is soft tissue injury on the medial side, what we were talking about earlier, if you can't reduce it, it's tip post, slip on the middle myelitis, and that's causing clot reduction. Soft tissue clot reduction. In terms of operative planning, this, I think, this fibula fracture is high enough, actually, if we're happy that on reduction, closed reduction, the fibula is at length, you can potentially ignore it and just fix it with isolated syndesmosis screws by your syndesmosis fixation by your chosen method on 2 screws. If there's any concerns regarding the fibula length, then we need to address the high fibula fracture first, fix that, and then fix syndesmosis as well.
That sounds good. So I think good. People are fixing really high fibula fractures. Going back to what we said earlier, that use anything you can to get your accurate reduction. So there are some people out there who are fixing proximal third fractures, and I don't know how. I've never done it. I think probably it's the sort of thing once you've done, you might not want to do it again. But often we say if you can see it on the ankle X-ray, you should fix it. So what happened here? So there we go. So that was. We're going backwards. So this was in theatre, and I thought I'll be clever. I'll open this. I know about these. You've got to get this accurately reduced. So I did an anterior incision, so I could see the reduction, and it's still really, really hard to judge. So that fibula I can translate north, south, internal, external rotation, posterior, anterior, and you can put it wherever you want it, and it's still really hard to see when you're reducing it. But I thought that looked quite good. It sort of matches the sort of, you talk about Shenton's lines matching the lateral process out of the talus. The gap here looks like this. They talk about the dime sign, you can put it down here. But once we put these screws in, it was then doing that. So we ended up going in. I went to the medial side and repaired the deltoid, and that seemed to stabilise it. I let Nick Murray measure the first screw, so then we had to redo it to get full cortices. And then because I was there, we repaired the anterior ligament as well. But you probably didn't need to do that. Do you guys have repaired the medial side if it's tilting like that, or do you think that you'd have got
Well, I
away
think
with
with the degree of displacement you had on that original X-ray, you could argue that certainly a big chunk of the deltoid has been torn, probably superficial and deep. So you don't often have to do it. If it doesn't look right, then yes. Same thing.
It's one of those age-old things that people say, "Oh, I never do it," and things like that. It's why make statements like that? You know, if you see something like that and you think, "I'm going to make this a bit better," what are your choices? Well, your choice is to go in and repair the deltoid. That's so.
I hadn't done it before. It's really easy.
Well, it's a big chunk
It's
of
just
tissue.
a big chunk of tissue, and you know how to use it.
And there's an
so don't
element
be
of
afraid of doing that if you need to.
sleeve of the superficial deltoid as well. But just the one thing about all of this that wasn't commented on is, okay, fine, there may be a natural lateral flare of this tibial platoon, but that's one of the reasons why low index of suspicion to do a CT. If you go back to the original X-rays, particularly that one, and
Just
you look
wonder
at the
whether
tilt on that and you just think, hang on.
Yeah, so he comes back, say, 4 or 6 months, and you just see his tibia going up there. You might look back at this, but that no one's got a good answer for that, have they? So even if you go in and crunch it back down
Well,
again,
we tried doing that over years.
Yeah, so
it doesn't. They don't do
you
well.
can get them with little anterior lateral incisions, and you can put them, you can push the surface down, graft it, and put a little plate on it. But whether it really makes any difference, but the dialogue that you're having with the patient changes, because if that's impacted on that joint surface in the tibia, then it's a bad injury, and you should be telling the patient that right from the start. You have got a crushed joint surface. That usually makes their eyes water a bit, because they sense reality.
So however, I've got a few more cases, or we can stop now. So call us 5 Friday. Very happy to do what the consensus is.
Mr. Harris and I getting Thursday.
Have you got a question?
Yeah, just one of your colleagues that Southampton does an arthroscopic assist reduction of these.
Yeah.
Because he's worried about the internal external rotation. How many of these personnel or consultants have adopted that approach? Sometimes it's tricky to find out if it is reduced or reducible.
I think the consensus probably is that most people would be quite keen to do that. You've just got to decide whether or not how much you want to piss off the scope team.
It's not off as much as I'm
Yeah.
pissing off when I scope with
Yeah.
Cal.
So yeah, I'm for the scopers, definitely, and it's a pretty straightforward thing to do.
So
but that's not necessarily the be all and end all, because
Yeah.
it's still hard to know what it
is
is.
that
it is unproven. But it is one of the ways of assessing whether you've got a reduction. And those of us who've got experience of doing it, you can actually see that the things reduce. And that's true of fractures on the joint surfaces, true of the fractures that are interact articular through the malleolar. But it comes down to a skill set. If you don't have the skill set, you can't do it. Oh, and there's the course we run to it. Oh yeah, you can pick up the skill set. Only costs 750 quid.
I suspect that even, so when I've thought about this with scopes, just doing normal ankle scopes, it's still quite hard to know exactly where it's meant to go. So I suspect, yeah, it's a bit like with the open reductions, there's this reported 15% malreduction. I should think even scoping them, you don't guarantee it. But I suspect with more experience, you get better.
So what a lot of American and German units would do would be to do an intra-articular or intraoperative CT. And that's a resource we don't have, and it costs a lot of money. Whereas actually putting the scope in will probably give you the same level of value. And it's cheap technology, it's available in most operatives.
Don't be afraid to X-ray the other side as well.
Yeah.
That's quite helpful. So have you guys had enough?
The other thing about scoping, you can say, if you do want to scope these jobs, the trauma ones, it's an absolute dream. Most times the ligaments are stretched, it's like driving a bus through the joint. You've got plenty of room to get a joint in, straighten the joints.
What's your visibility like if you've got hemothesis? Is it reasonable still?
Same as it would be if you're doing a knee